Hello, everyone. Hello, everyone. We'd like to get started. We know that people are still in line for food. If you guys wouldn't mind moving over just a little bit the lunch line so that people can see the screen. But we appreciate you guys here, and we don't want to keep anyone, we want to be respectful of your time today. So welcome. We're very excited to see all of you. Last year, it was more of a COVID classroom, being socially distanced and grab-and-go food and masks on and stuff. So we're excited to have everyone here in person right now. Please feel free to grab some lunch, generously donated by the Compass Group. It's delicious. So grab it, sit down, and please feel free to enjoy it throughout the program. I'm Denise Hurley. I'm the publisher of Medical Professionals Charlotte and Medical Professionals Triad magazines. They are peer-to-peer magazines for physicians in the area and those in the healthcare community, and the goal is to connect the healthcare community in the area. I'm also a member of Healthy Charlotte Alliance, and I'm very excited about that. So, as many of you know, Healthy Charlotte Alliance is a local nonprofit that was founded 81 years ago with the mission of improving the health and quality of life for all people in Mecklenburg County. We fulfill this vision in 3 ways. First is health education programming, convening experts to deliver educational programs on relevant and timely health topics like today. The second is volunteer programming, engaging members who volunteer their time through meaningful service opportunities with local health nonprofits. And the last is grant making, financially investing in health programs demonstrating proven impact in the community. In sum, it's health education, service, investment, and most importantly, impact for our local community. So before we get started, I want to thank the Compass Group for their generous donation of this delicious lunch. They are our transformation sponsor, so let's give them a round of applause. We also have a number of other sponsors to thank. Our prevention sponsor is Novant Health. Our wellness sponsors are Atrium Health Foundation, Bragg Financial, Coca-Cola Consolidated, Kelly and Meredith Graves, Providence Anesthesiology Associates, and Steve and Beth Purdy. Our partnership sponsors are Alliance Health, Leslie Aronovich and Ted Gearhart, Carolina Asthma and Allergy, and Dr. Emily Langley, Karen Chandler, Dr. Ken and Mimi Compton, Novari Capital Management, Rankin OBGYN and Dr. Simon Ward III, Reproductive Endocrinology Associates of Charlotte, REACH, Dr. Carl and Joan Scharf, Dr. John and Becky Williford, and Mrs. Mitzi Yount. So special thanks to our host sponsors, Dr. Addison and Kendra May, and Dr. and Mrs. Simon Ward III. Thank you, everyone. Additionally, I'd like to recognize Healthy Charlotte Alliance's Legacy Society. These individuals have left a legacy gift for Healthy Charlotte Alliance, which will provide lasting sustainability, helping to ensure our mission lives on for another 81 years. Please stand when I call your name. Leslie Aronovich, Karen Chandler, who unfortunately was not able to make it at the last minute, Sherry Ward, and Mincy Yount. Please know we deeply value and your generous commitment. Okay. And last but certainly not least, I'd like to thank and recognize all of you, all of the members of Healthy Charlotte Alliance. You're the heartbeat of what we do, and we're grateful for your unwavering support. Speaking of the group and membership, you might be thinking, okay, who's the ideal member for Healthy Charlotte Alliance? And the answer is anyone that's passionate about health in our community. Healthy Charlotte Alliance's membership is made up of men and women who may work in healthcare or simply enjoy learning new things, who want to live a healthier lifestyle or want to see a healthier Charlotte community. No matter race, gender, socioeconomics, or zip code, and they simply want to make an impact. So, now that we've covered who we are, let's talk about why we're here today. In addition to our lunch and learns on timely and relevant health topics, Healthy Charlotte Alliance's annual signature health education program is the Community Health Classroom, and today we'll be examining community violence from a public health approach. Our distinguished presenters will each share with us and join us back on stage for a moderated discussion afterwards, and Q&A session as well. Health experts Dr. David Jacobs and Dr. Samuel Pullen will examine community violence as a disease and explore treatment and prevention strategies, as well as the impacts of mental health on community violence. Next, with an extremely relevant element to the conversation, school safety expert Charlotte Mecklenburg Police Lieutenant Stephen Flatt will share strategies and actions to prevent violence in our schools. I'm sure you're going to have some important questions as we move through today's program, so please either make a note in your phone or there should be paper on the tables for you to jot down questions, and we can answer those later during Q&A, but your voice is a vital component to the effective treatment of this public health crisis. So today's discussion is heavy, and it involves some of the most sensitive and charged topics these days. You almost can't turn on the news without hearing about something. My humble request is that you approach this program with an open mind and open heart. And while you may hear something today that you disagree with, if you keep your ears, mind, and heart open, you may also learn something that you did not know, never thought of, or better yet, feel empowered and emboldened to impact for the better. So at this time, I would like to invite our first presenter, Dr. David Jacobs, to the stage. Dr. Jacobs is the Medical Director of Trauma Services for Atrium Health. He held a Trauma and Surgical Critical Care Fellowship and a Pediatric Surgery Research Fellowship at Maryland Institute for Emergency Medical Services Systems. He also held a Pediatric Surgery Research Fellowship at the Hospital for Sick Children in Toronto. Graduating from Weill Medical College of Cornell University, he held residencies at University Hospitals of Cleveland and Hospital of the University of Pennsylvania. His accolades include the Charlotte Area FBI Community Service Award, the Pride Community Service Award, the Martin Luther King Jr. Medallion Award, and the Carlton G. Watkins Award for his commitment to Charlotte's youth community. Dr. Jacobs, thank you for being here today. Thank you. And you can, oh yeah, take the stage right here.
Oh,
all yours.
Thank you. Good afternoon, everyone. Thank you. I feel like I'm in church. Good afternoon, church. So thank you for that very warm introduction. I couldn't have written it better myself. Sounds like I did write it. But there is a correction. I'm no longer the medical director of Atrium's acute care surgery trauma program. That guy is right there somewhere, Dr. Addison May, who was one of the table sponsors today, so please give him a hand. So you've heard that this is a pretty charged topic, and I'm sure that I'll say some things that not everybody will agree with, but I do look forward to the conversation that we'll have at the end of this. And so let's just go ahead and get right into it. We always start our medical talks with the disclosure slides. So I have no financial relationships to disclose. I wish I did, but I don't. And my other disclosure is I'm a trauma surgeon. So I don't have a background in epidemiology or sociology or any of the other backgrounds that traditionally would handle the topic that we're getting ready to talk about. But I do believe I've got some credibility by virtue of what I've seen every day as a trauma surgeon. This is my final disclosure, and these are my three sons. This picture is rather old now. It's probably 8 or 10 years old. They're all young men and out of the house now. But I list this as a disclosure because they're young African-American men. And so what we will hear today is that when we talk about the public health approach to violence prevention, we will hopefully understand, I'll hopefully convince you that this is a disease that predominantly affects young African-American men. And so when I got interested in violence prevention, I won't tell you how many years ago, I had ulterior motives because I wanted to make sure that my sons didn't become victims of interpersonal violence. So those are my disclosures. Here's what we'll try to cover in the time that we have together. We'll talk a little bit about what violence is, many different definitions, and We'll go over some of those. We'll go over some of the causes, because I firmly believe you really can't talk about interventions without really understanding where the disease comes from. We'll talk a little bit about prevention and what your role it might be in thinking about prevention here in Charlotte, which dovetails into what we can all do together about violence. When I started giving talks many years ago, I was told when you address an audience like this, you tell them what you're going to tell them, which is what I've just done. You tell them, and then you tell them what you told them. So I've told you what I'm going to tell you. I'm getting ready to tell that to you, and then then I'll tell you what I told you. Here's the CDC definition of violence, and you can read it as well as I can, but I would call your attention to a couple of important words here. First word is threatened. And so you don't actually physically have to lay hands on somebody for you to fulfill this definition of violence. Physical force or power is obviously an important component of this. And then the final component that I will call your attention to is against another person or against oneself. So we don't often think of suicide, self-injury as a form of violence, but certainly in the CDC definition, we need to think about that. We won't talk a lot about suicide, or perhaps hardly any. We have folks coming up after me who are more expert in that than I am. But in the spirit of being complete, I certainly want to mention that. I also want to mention that words matter. And you'll see on this slide so many of the words that we throw around when we're talking about this issue of violence. You hear gun violence, you hear firearm violence, you hear firearm injury. And so I'm not going to go through these individually. We'll make some distinctions as we go through this. Some are the same, some are equated but are not the same. And so when you have a conversation with other people, I think it's important for you to know what you're talking about, because the statistics can be bent in a particular area to suit your side of the argument. And all this is against a backdrop of age, race and ethnicity, socioeconomic status, as well as other factors. So all of these things sort of play into the definition that we need to talk about. This is just an example of that. This shows what's been going on in this country for the last 30 to 40 years as far as violence is concerned. You can see at the bottom, stab wound, blunt assault, other types of firearm injury as opposed to handguns. But what you can also see is that the majority of the trends in violence in this country have occurred as a result of handguns. And so you will frequently hear people talk about gun violence in an equivalent fashion to violence, but understand that there are other forms of violence. And so you'll hear me today talk about gun violence primarily. It's not because I have an anti-gun agenda, but it's because a lot of the violence in this country is really driven by the handgun. So pardon me if I use those terms interchangeably. When we talk about violence, we already talked a little bit about suicide. There's obviously a lot of attention being paid nowadays to mass shootings. But I want everybody to understand, and I think this audience understands, that as tragic as those events are, they account for a very, very small percentage of the folks that we lose every year in this country to violence. We lose many more people to suicide, many more people to the everyday drone, if you will, of community violence. And so you see a lot of outrage when we have mass shootings, and rightly so, but I think we need to pay attention also to the more ordinary, unfortunately, community violence, if you will. This is information that I think you probably know, but violence is not random, and this is just what we are seeing this year. So this year is not over, but you're seeing a predominance of violence in the right side of the country. No political intent there, but on the right side of the map. And you can see where we live in the southeast, particularly around Charlotte, around Atlanta, around our major cities, New York, that violence is a real issue. No surprise to you. We'll talk a little bit more as we go through this about, we'll focus in a little bit more on what's going on in Charlotte. Again, no surprise to you. We lead the industrialized world, the high-income countries. We lead them in both suicide and homicide. I'll refrain from making any comments about gun ownership in those countries, but there is a correlation, and we'll leave it at that. So how did we get here? And this, what you see here is really a longitudinal look at U.S. homicide rates. Now, again, I'm conflating homicide with gun violence, with violence. We do that because homicide is easy to measure. You're either dead or you're not. But I will tell you in a slide that's coming up, I will tell you that the toll of gun violence goes way beyond homicide. Most of us have been impacted by gun violence in one way or the other. We know someone who's been shot. We may have been victims of violence ourselves. And many, many, many more people are injured but don't die as a result of gun violence. We don't have a good handle on how big that problem is, but we know it's a major problem. A lot of those are not reported to our law enforcement folks, so we don't really know what the extent of that is. We're trying to figure that out. But I'm using here homicide rates because it's easy to measure. And you can see, and you'll hear people tell you now, violence is not a problem. We've dropped violence rates significantly in the last 20 or 30 years. That's true when you look at the slide. Violence tended to peak in the early 90s. No one really knows why that is. Some people say it's because of the crack epidemic in our cities. There may be many reasons for that. And they're right. Violent rates really dropped between 1990 and 2010, 2015. Again, we don't really know why that is, but obviously that was great news. I've been in the violence prevention arena for X number of years, and we took credit for this. We said, well, medical care is getting better, we're doing better with social programs, we know why this is happening, and it'll be easy to sustain this. This is another reason why I conflate gun violence with violence. When you look at how Americans are murdered, and we're back to that homicide thing, you'll see that the vast majority of folks are injured by firearms. And so whether you're talking about firearm violence, gun violence, firearm violence obviously includes long guns, it includes semi-automatic weapons, it includes many different kinds of firearms. So know whether you're talking about handgun violence or firearm violence or what you're talking about. So the point of this slide is, again, that violence really in this country really sort of turns out to be gun violence. I told you I wasn't going to get political, and I'm not, but you hear this all the time. Guns don't kill people, people kill people. And I would suggest to you that guns don't kill people, but it certainly makes it a lot more lethal, a lot easier to kill people. And this slide basically shows, you can see the bottom line at the bottom of the slide, if we decreased gun availability, however you want to define that, but if we decreased gun availability in this country, we would drop our violent death rates by 80%. And when I go out and talk to kids in the schools, I say, if you're 6'5", if you're 5'2" and you're having beef or you're having trouble with the same person in your class who is 6'5" and weighs 240 pounds, are you going to go up to him and punch him in the face? The answer is probably not. But if you have a handgun, and we're seeing more and more violence in our schools, you have a handgun, all of a sudden the playing field is level. And so although guns don't kill people, they certainly make it much easier for people to solve conflict. Easier, not better, but they certainly make it easier. And so I don't think I'll get any more political than that. Here you see that same trend, that downward trend from 1992, but this looks at the impact of race and gender. And what you see here is that this is a disease of black males. That graph that I showed you is driven entirely by what's happening with black males in our country. You can see white males, white females, black females here, but by far, that overall graph that I showed you earlier is driven by what's happening with our African American males in our major cities. This breaks it down a little bit beyond black and white. You'll see Hispanic here, you'll see Asian. And so as we broaden our lens, we can see that this is really a disease of men of color, driven primarily by African American men, but by no means are Hispanic males and males of Asian descent excluded from this. Here's the impact of age and why at least my focus is on youth violence. And you can see in this slide that if you're around the age of 15 to 18, 15 to 19, those rates are the highest rates we have in gun violence in this country. That might not be a surprise. Their frontal lobes are not fully developed. There's probably some psychologists and there's some mental health folks in here that can tell you about the amygdala and all those other kind of things that drive this. But you can see that there is a significant age difference, and my passion, again, is around looking at youth violence, depending upon how you define it, 15 to 19, 15 to 24, 15 to 29, whenever that frontal lobe finally gets developed. As I mentioned to you, I've got 3 sons in their 30s, and I'm not sure their frontal lobe is completely developed yet. My wife would tell you that my frontal lobe is not completely developed yet. So let's look at youth violence, and you can see some of the causes of death for our kids in this country. The study came out of the University of Michigan, and the numbers here are not important, but what is important is that we've made significant progress when we talk about youth health, in motor vehicle crashes, in cancer, in accidental injury and suffocation, but we've made no progress as far as firearm injury is concerned. In fact, in this country, we have crossed a nexus where more kids are dying now, more Americans are dying now of firearm violence than motor vehicle crashes, which is really a stunning development. Here's some statistics. In the interest of time, I won't go over it, but 13 kids die a day of gun violence. You can see some of the toll there, both in terms of cost and in terms of life lost. Here are our homicide rates for youth violence. I mentioned earlier, our overall rates are driven by African American males, and you can see here when we talk about youth between the ages of 15 and 34, it's a generous definition, those trends continue. And I mentioned before, non-fatal firearm injury, really don't have a good handle on this, but some people have said that fatal firearm injury accounts for 1 or 2% of the overall injury that we see from firearms. So we talk about firearm injury versus versus homicide. Again, those words are sometimes used interchangeably, but are certainly not the same thing. And then finally, looking at socioeconomic status, this slide's a little bit difficult to interpret, but basically what it shows is that as your poverty level increases, you're more likely to be a victim of violence, certainly more so during your early ages than you are as you get older. And so we do have a public health problem. I made this slide probably 10 years ago, 2014, 2015, when those rates were still declining at the end of that curve, saying that violence is a disease of young and poor men of color, with the handgun serving as the most common disease vector. I'll keep emphasizing that word disease. We've seen to have made some progress, but we have a lot more work to do. I made that slide in 2014, 2015. So what's happened since then? You can see at the end of the slide a disquieting trend that began around 2014. Rates began to go up. Folks begin to say, is this just a blip, or are we seeing a resurgence in violence rates? 2016, 2017, you can see both suicide and homicide rates are steadily increasing. We no longer believe this is a blip, but this is a new trend. 2017, we set a new record, or so we thought, with both the incidence of violence and the overall numbers of death. That was until 2020 when we set another record. This is from the Washington Post. A lot of folks ascribe this to COVID. Folks were pent up. There was a lot of mental health issues. And so we anticipated that in 2021 we would finally see a decline in violence. You can see here, this is again 2020. Charlotte's down there at the bottom, one of the cities, one of the largest 15 cities in the country that experienced a significant increase in overall homicide. This is violence in Charlotte. You've probably seen these numbers. I can't see them from here, but what you can see is a steady increase. And really, this is what got the attention of the folks in the city and the county, that something needed to be done. Here are our violence trends. You can't see them probably because the numbers are small, but whether you're talking about pediatric, adult, geriatric, our numbers have exponentially increased at the trauma center. Most worrisome in that pediatric age group, where they've tripled over the past 10 years. So we're seeing what everybody else is seeing. So this gives you a real trend over what's happened over the last 30, 40, 50 years, and you can see we're back where we started. If you go back to 1970, 1975, you can see that the rates are just as high as they were, almost approaching what the rates were when they peaked in 1992, 1993. We don't understand why this has happened, but this takes us through 2020. We're back where we started until we got to 2021, and the numbers continue to increase. We don't know why. There's a lot of theories out there, but the numbers are continuing to increase, and the question becomes, when will this end? All right, so that's the first part here, maybe the depressing part. So what causes violence? And people have posited various things: guns, gangs, drugs, media, alcohol, whatever. But I would suggest to you, and my thinking has evolved over the years. We spent a lot of time hammering the media about violent music and violent movies and so on. And I guess my belief now is that those are symptoms of the disease, but not the cause. And so we see, like in any other disease, there are symptoms, but unless you treat the cause of the disease, you're not going to get to the bottom. And so I like this slide because it talks about the roots of violence, and I won't get into all of these. You all are very familiar with the concept of social determinants or social drivers of health inequity, and I think the same structure, same scheme applies to what we're seeing in violence these days. And so until we deal with these issues that you see on this slide, racism, poverty, lack of education, those kind of things, we're going to be plagued with this issue of violence, I believe. And so what is the public health approach to violence reduction? We treat it as a disease. We know their causes. We know their symptoms. We know their solutions. And so it makes every bit of sense to think about this very much as a disease. You probably know this as well, but I find it very, very true in my daily practice. Your zip code is more important than your genetic code in predicting your long-term health. Where we sit here in Myers Park is about 6 miles away from the Beatties Ford Road corridor. There's a 16-year life expectancy if you travel that 6 miles. And so your zip code clearly determines a lot more than education, than all of these things, and certainly more important than the genetics. If you haven't seen this report, it comes out of UNCC talking about the racial wealth gap in Charlotte. It's full of useful information talking about the justice system and housing and education. It's really worth taking a look at. So here's that same slide. There's a lot of you folks that work in youth health, and you've heard the term ACEs before. You know about this in your sleep, but I would suggest to you that ACEs stand for other things, in this case, adverse community environment. So adverse childhood experiences, yes, but think about adverse community environments and how they will impact violence as we go forward, how they impact access to guns, the same issues. I apologize for moving through this quickly, but I do want to move on to the uplifting part of this. You've also heard about the concept in Charlotte of the arc versus the crescent, and the crescent versus the wedge. This slide talks about the arc, which I guess is the same thing as the crescent. And so I want you know this pattern, but when you superimpose homicides in Charlotte over this map, this is what you get. You get that same pattern. And so if you don't believe that zip codes and social determinants of health have impact upon violence and may be the cause, hopefully this slide will convince you of that. And this slide talks about social determinants of health and what happens in our communities when things change. So whether the income gap increases, whether we have more social service programs, have a significant impact upon violence. This is not Charlotte, this is nationwide. But you can see the more money we spend on the front end, the less money we need to spend on the back end in terms of violence prevention. So how do we go about doing this? This is a community approach. We talked now about communities and what impact they have on violence. There's a number of different ways that you can look at this in a number of different interventions. I'll talk a little in a second about the hospital-based violence intervention methods, because that's sort of what I do. You can see here, this is an overall public health approach schema that I believe will be helpful to you. And so we talked about neighborhood factors, but they're not the only factors. There are peer factors, there are school factors, family factors, and individual factors. And so how those weigh, the relative weight of those factors, I believe, will determine whether we have violence or whether we don't have violence. And so the question you frequently hear is, if community is so important, why do we have kids from the same community turn out so differently? And that's because if you have more protective factors, then you have risk factors and you're going to have resilience. On the other hand, if you have more risk factors and you have protective factors, then you're going to end up with violence. And so our role, I think, as a community is to try and minimize those risk factors, maximize those protective factors. How do we do that? We have primary prevention, secondary prevention, and tertiary. Primary is directed at all your citizens, secondary to at-risk youth, and tertiary to those that have already been infected, those folks who have already experienced violence. So let's look a little bit very quickly at primary. This is a really old slide from 20 years ago. We did something called Camp Resolve at the hospital, where we brought folks in and asked them to see what it was like to be injured and talk about some of these underlying causes. So that might be an example of an at-risk group or a secondary intervention as far as violence is concerned. Moving on to tertiary, I sort of skipped through primary, and I shouldn't have done that because this is a very medically oriented audience. So whether you're a physician, whether you're a nurse, whether you're a medic, you have access to patients that come into your office that you can talk to about guns, talk about risk factors and protective factors for violence. There are those who would want to prevent you from having those kinds of conversations, but I would certainly encourage you to do that. Tertiary prevention is where the hospital comes in and we see patients that are injured, and it's our opportunity to perhaps use those injuries as a teachable moment. So the patient comes in, they're injured, they're assessed through a structured assessment. During that window of opportunity, we determine what their risk factors are, what their protective factors are. We try to maximize the protective factors in what we call a hospital-based violence intervention program, or HVIP. And that's a comprehensive review. Do they need drug counseling? Do they need GED? Do they need education? Do they need housing? Do they need food? Do they need transportation? All with the idea in mind of reducing their chances of becoming violent recidivists, because we know that upwards of 25 to 40% of patients who present with violence will present with violence again or will become perpetrators of violence. So we have HVIPs across the country. We don't have any established HVIPs in North Carolina, but I'm proud to say we are the first at Atrium There's other activity going on at Duke and at Wake, but we're the first, and even here at Atrium, we are only in our infancy. They do make a difference. There's a lot of data that suggests that these things save money, they save lives, and they really change attitudes. So we will continue to do that. Here's our approach at Atrium. I just described it to you. We see folks between the ages of 15 and 24, 25, because, again, that's a high-risk group. We assess them, and then we refer them using Aunt Bertha, which many of you probably know about, figure out what their social needs are, and get them hooked in with Aunt Bertha, but we follow these folks to make sure that things are happening. How else is Atrium engaged? A number of different things. Gun locks. We have an annual youth violence prevention conference. There's a number of different things. I won't read through them, but just know that Atrium is engaged and trying to become more engaged around this issue of violence prevention. What else is going on in Charlotte? You've seen this before. There's a number of things that are going on in the community. There are folks in this audience who are much, much, much better versed at talking about this than I am. Tracy Campbell, who's down in front. Tracy, raise your hand. Tracy is a traitor. Tracy used to work for us at Atrium as our injury prevention coordinator. She was lured away because of all the knowledge that I shared with her. She ran with that to the county and is now the manager of the county's violence prevention office. So I applaud the county for establishing that office. I don't applaud them for stealing Tracy. But I do applaud them for having the foresight to put together an office which is really focused. And so these next couple slides come courtesy of Tracy. You can see what their mission and vision is, and we wholly support that. It is a multi-dimensional, multi-institutional approach. You can see CMPD, you can see Atrium. Alternatives to Violence is the city's, I would say, major violence intervention program. They're working with the folks in Cure Violence. If you don't know anything about violence, Cure Violence is a program that was piloted and developed in Chicago, and I think the only evidence-based community-based violence intervention program. So that's here in Charlotte now. So a lot of things going on. That's the Alternatives to Violence program that I just mentioned. So I'm done. I hope I've convinced you that violence can be thought of. So I'm telling you what I told you. Violence can be thought of as a disease. You can see specific interventions, et cetera, et cetera. I believe guns do kill people, or they certainly make it easier to kill people. My 30 minutes is up, and I'm on my last slide. Who knew? Healthcare providers, healthcare encounters, and healthcare systems, I believe, provide a unique opportunity to really intercede in violence. And I would encourage all of you. I know that we really didn't get into a lot of depth, but I do believe that there's something, for some reason, maybe the most important slide didn't come up. It was titled, What You Can Do. But you can certainly, in your spheres of influence, you can certainly, whether it's mentoring, whether it's teaching, whether it's being a big brother, big sister. We don't think of those things as being violence intervention strategies, but certainly they enhance those protective factors, which in many situations is all we can really do. We don't have a lot of control over the community risk factors, and sometimes not over the family, not over the peers, but we can alter that balance with enhancement of protective factors. So I'm going to stop there and really, really looking forward to the discussion that ensues. Thank you very much.
Thank you, Dr. Jacobs. That was a lot of good information. And I think a lot of us know that and have an idea of the numbers, but to see it makes even more of an impact. And when you talk about words matter, I think that's true. And I think, I have 3 teenage daughters, and I think because of social media, a lot of kids become desensitized to certain words and things like that. So, okay. So next, let's see here. We have Dr. Pullen coming up. Where is he? Dr. Samuel Pullen. Head on up. Dr. Pullen is a general and child adolescent psychiatrist and physician executive with diverse clinical, administrative, and public health experience. His areas of professional interest include community, rural, and global health, integrated care, and health system economic and social determinant factors that are interconnected with access to health care in communities and neighborhoods. He currently serves as the System Physician Executive for the Psychiatry and Mental Health Institute at Novant Health and is an adjunct professor of psychiatry at the Duke University School of Medicine, Department of Psychiatry. Dr. Pullen received his medical degree and master's in biomedical sciences from A.T. Still University, Kirksville College of Osteopathic Medicine. He completed his residency and fellowship training in general and child and adolescent psychiatry at the Mayo Clinic, Rochester, Minnesota campus, and completed his Master's of Public Health at the Johns Hopkins Bloomberg School of Public Health with certification in Global and Community Health. He is currently a student at the Johns Hopkins Carey School of Business and the Stanford Graduate School of Business, where he is pursuing his Master's of Business Administration and Healthcare Management, Innovation and Technology, and LEAD, standing for Learn, Engage, Accelerate, and Disrupt certification in organizational leadership, respectively. Thank you, Dr. Pullen. I mean, between the two of you and all of your accolades and titles, you're making me work for this today.
That's actually embarrassing when I hear somebody else say all of those things. My first disclaimer is that Dr. Jacobs and I have not had the pleasure of meeting. And I really appreciated his presentation. As he was giving his talk, it occurred to me that this is going to be a retread of his presentation in a lot of ways. So you have both a trauma surgeon and a psychiatrist really essentially looking at the same data. And even though we have different perspectives on this topic, we're really, I think, coming to the same conclusion from a medical perspective. So if you'll indulge me, a lot of the data that I'm going to present, you've just already seen. My hope is that with this presentation, I can put maybe a little bit of a mental health and public health slant on it, but Dr. Jacobs is wrong. He actually has a lot of public health credibility. A lot of the data that he shared is data that and work that public health experts across the country really are looking at and have come to the same conclusion. I also don't have any disclaimers to share with you in this presentation. So I think, as we've already heard, the impact of community violence is significant. And from my vantage point, really a big part of the why for me was really coming from a provider, physician experience. So much of my work in the clinical arena of child and adolescent psychiatry occurred in the emergency department. And so a lot of my work was with young people coming in and certainly addressing a number of different mental health conditions, but also the impacts of community violence, all of the social determinant factors that you've already heard about. But just to share a few statistics around the impacts of community violence, as you can see here, 25,000 lives lost to homicide in 2020. 1.4 million people treated for assault in emergency departments. And then, as was already mentioned, a lot of this is occurring among our young people. Over half of homicides occurred in young people ages 15 to 34 in 2020. Community violence is not only a cause of physical harm and death, but also an important cause. There's an important relationship, I should say, between community violence and mental health. And so we certainly see some of the mental health symptoms associated with community violence, that being depression, anxiety, trauma, and substance use. But I would submit to you that there's a cycle, a vicious cycle here, not just at the individual level, but really at the community level. And that's where a lot of my interest in this topic has occurred. Living in communities affected by recurring violence is associated with increase in risk of also developing chronic disease. So a variety of chronic medical diseases. And we see that in neighborhoods, particularly neighborhoods of color, neighborhoods of lower socioeconomic status, where we see the impacts of violence, right, of things like food insecurity, home insecurity, and so forth. And again, all of this creates this really kind of vicious cycle. This occurs because community violence prevents people from engaging in health or wellness behaviors, or behaviors that really encourage their own growth. It strains education, our justice system, our medical systems. And so this is, the impact is significant, and I think there can be really no bigger why, in terms of why is this such an important topic to address. I mean, I think that the question, and I think this is a question, I think, for all of us, and this is a question, whenever I get in front of audiences, I like to really engage our audience, and so likewise, I'm looking forward to the discussion. But is it possible? Is it possible to prevent violence in our communities? And hopefully all of us are here saying yes on some level, right? Otherwise, we wouldn't be here if we didn't believe that. But yet the statistics are so startling, and so as we think about the complexity of the problem and the barriers, I think that's really important to take a step back and look at that. So this is part of that retread that I was promising you, or the start of that, so sharing similar statistics. So I became really interested in this problem when I was getting my public health training, and this is what I did my practicum and research on when I was at Hopkins. I became really interested in this because when I was doing my training there, I was really struck by the neighborhood in which the medical programs of Johns Hopkins resides in. So if any of you have ever visited Hopkins or visited East Baltimore, you can really appreciate, I think, what sometimes is described as the tale of two Baltimores, right? There's East Baltimore, where there is significant poverty, where there's significant violence, and that's displayed here, where there is significant housing and food insecurity. My roommate that I was staying with when I was going to school here had described this as the Middle East of the United States, and that was a reference to the just how much violence was occurring. And that's played out in statistics when you look at Baltimore compared to other major cities in the country. A lot of my work was with the Big Cities Health Coalition, which is a collaboration between many of the major metropolitan areas in the country, where they do a lot of data sharing and really come together around big public health initiatives, with community violence being one of the recurring issues that cities are coming together around. So with data sharing, that the hope is that that then leads to, okay, well, what is one city doing right? How can we borrow and exchange ideas and learn from each other to address similar problems that we're having? As a case in point, in this particular data set, you can see the gun death rate in Baltimore, which is the highest. And you can look, I also put a couple of other notable cities there. So you can see where Chicago lands relative to its counterparts. You can see where Charlotte lands, and this is 2020 data. And then you can see where New York City lands. And so I found that very interesting. And so is there something about New York City that's different there? And it's not that New York City doesn't have its problems or its own issues with racism, with community violence, with all the social determinants of health, but there is something different about New York City when you look at gun violence compared to a place like Baltimore or a place like Chicago. And so I think that's really the power of looking at data like this and starting to think about how do we solve a problem as big and as complex as community violence. I don't know the answer to that, by the way. And it just makes me, being a physician and a scientist and researcher, it just makes me ask the question, and hopefully would maybe make us ask that question. Like Dr. Jacobs, I also conflate gun violence with when we talk about violence, and I won't retread what he shared about that, but it's for the same reasons that he shared with you. So this is another look at some of the same data that you've just already seen. And so between 2019 and 2020, there was almost a 30% rise in gun-related deaths. Most of that was due to homicide, but the gray bar also includes both homicide and suicide, and the much smaller percentage of accidental death by firearm. And you can see those trends year over year. As was already stated, there are probably a number of factors with the central role of the pandemic, thought to be playing some kind of part in all of this. But it really, I think, rather than a causative agent, I think of the pandemic as more both of perhaps exacerbating the problem or maybe unmasking the problem, right? Maybe unmasking some of the other challenges that have been really root causes, things like structural racism. I think even though we don't like to talk about politics because of the tenor of conversations, especially nowadays with how deeply divided our politics and conversations seem to be. It's important to acknowledge that that plays a central role in a lot of this. So when we think about efforts to have responsible gun laws and gun control, while balancing that with things like our Second Amendment rights, politics is inevitably inserted into those conversations. And then we think about also conversations that have been had around the law enforcement. And I'm really looking forward to hearing from our law enforcement colleagues and getting their perspective on this problem. But that also has been, that's something that, when we talk about community violence prevention, what is the role of law enforcement in helping communities come together and solve those problems? So this is really an intersection, right? So this data, again, I think tells a story. And the story is that we are seeing this rise, and I think it's incumbent then on all of us to say, why is that? What's different? What's changed? And clearly the data and the trends are going in the wrong direction, or at least have been. And so that's, I think, a call to action. This data is basically telling you the same story again that you just heard when we think about the relationship between violence, gun violence in particular, and gender, age, race, and ethnicity. My own only plug for anatomy and physiology is that it is in fact true that women's brains on average do develop faster and mature more quickly than men's brains do. And so that's not just an observation. There's a lot of science to back that up. But what we do see significant differences in death rates related to firearms in young men versus young women. We do see significant differences in death rates in young black men compared with other racial groups. And we do see significant differences by age demographics. Most of the deaths associated, as you can see again, represented by the gray bars as people get older, tend to be related to suicide. And in young people, most deaths related to firearms tend to be related to homicide. Although I don't have this slide here, just to reference back to the slide that you saw where you saw the vast majority of on the East Coast gun-related violence and homicides really kind of being saturated in the eastern part of the U.S. If you were to overlay that map with the CDC's map related to suicide, you would see a significant swath or belt of suicide in the western part of the U.S. And so Idaho, which is where I hail from, has the sixth highest suicide rate. And then you look at other states like Utah, Wyoming, and so forth. And there's significant gun ownership there as well. So again, there's connections there, and it's impossible to ignore those connections and associations. So this is the slide that I spent, that really, it's not that graphic isn't my graphic, but it illustrates a lot of the work I was really interested in when I was studying this problem. And that's the role of, and again, you saw a different version of the same slide. I think Dr. Jacobs and I both really like, I think, this idea of looking at root causes and how this perpetuates this cycle. I was looking at it from the perspective of adverse childhood events from a mental health perspective and how that influences and shapes individual behaviors, and then ultimately how that comes together to impact communities. And so the study, the famous study that was done by Kaiser Permanente, and this was back in the 1990s, the original study was a review of 9,500, give or take, records, and looking at, or what they did is they interviewed adults and started just asking them about childhood experience. The original study focused largely on a predominantly white population. And so, and even when you were looking at a predominantly white population, when they started seeing the impact of 4, when you had a ACEs score of 4 or higher, that was predictive of bad outcomes in adulthood. When subsequent studies went back and looked at ACEs among minority populations, the impact was amplified significantly more. And then that's when people started looking at, well, the second ACEs, right, which is when we start to think about our communities and the impact of our communities. And so I became really interested in this idea of trauma, PTSD, not only occurring at the individual level, but I think that this also occurs at the community level. And there's a correlation, right, between, symptoms that a person may experience who's experienced trauma in some form or another. And there's a series of different kinds of symptoms that we experience. And if we've experienced recurring trauma, patients can become really kind of desensitized to that in a way. The brain engages some different defense mechanisms to defend against the impact of that trauma, but it often tends to be pretty maladaptive. But that's what the brain does to try to cope with in some way. And if there's a recurring trauma to that individual, that can become, in essence, a new normal for them if without appropriate intervention and opportunity to heal. And my belief is that the same thing happens in our communities as well. A similar phenomena happens, and which would make sense, right? Because our communities are a composition of people. And so I think that's where a lot of our roots lie. And so there's that connection, right, then between ACEs and violence and poverty and homelessness. And a number of interventions across the country, and you saw some of these interventions that have been done here in Charlotte, but really across the country, have focused on upstream and downstream factors, right? They've focused on those different, the primary, secondary, and tertiary public health interventions. And those, I think, are really important. When I started looking at interventions that different communities in different cities had engaged in, the successful ones had some common recurring ingredients, and I've just described them here. So I'll kind of say some of them because I think that they're important to hear as well as to read. But local community engagement, and particularly engagement that encourages our young people to be part of the solution, was critical for successful programmatic ingredients, right? Community leadership, again, at the local level, so that you didn't necessarily have so-called experts kind of swooping in and telling communities how to solve their own problems, right? There's certainly a role for expertise in different venues, and that's important. But the change also has to come from within communities, and that was a recurring theme in successful programs. We can't address community violence without addressing and talking about structural racism. That's such an important issue to address. It's important to have honest conversation and dialogue about other hard topics, which is sometimes something that communities tend to shy away from, like some of the political conversations, right? And the role of law enforcement, and going back to how do we have conversations about racism and the role that structural racism has played in community violence. We improve what we measure, right? So that's kind of one of the axioms of research and public health data. And so successful programs, Philadelphia is an example of one, that successfully really used data, and data was very data-driven in helping to promote change in some of their neighborhoods and communities that were most affected by violence. Cross-cutting collaboration. All of us here in this room and in our communities come to the table from different perspectives, and I think that's powerful, and that's really important. Because this is such a complex issue and problem, different perspectives are needed. No one perspective alone, I think, can solve such a complex problem, but collectively, I think that's a necessary ingredient. So having a cross-cutting approach to collaboration and partnerships is critical. Where programs maybe have initially succeeded but ultimately struggled to maintain results is when they weren't taken to scale and they weren't sufficiently funded, or there wasn't a mechanism for sustainability. And that is also a recurring theme to this to this challenge. So I've just listed here a few of the programs. I had looked at a number of programs across the country. And the one that I had wanted to call out was a program in Massachusetts. Actually, Boston has done a number of successful initiatives, but you can see just the impact of their SSYI program and the economic impact and the community impact that their program had. Again, when these programs are invested in and there's a sustainability mechanism, that's when these results persist. And so being new to Charlotte, I'm fairly ignorant in terms of what's been tried here in our communities here. And so these are some of the questions I like to ask when I'm in front of groups or communities and we're working together to try and solve problems like what we're talking about today. And so I think these are really meant to be questions for us to think about and reflect on, especially as we start to have more discussion here in just a little bit. And so that's the end of my presentation. Thank you.
Thank you, and welcome to Charlotte. And I'm glad to hear that Boston is doing well because I'm from Boston, so it's always nice to hear. So at this time, we're going to switch gears just a little bit. We're going to hear from a school safety expert. As you can imagine, school safety encompasses multiple facets ranging from bullying to cyberbullying to conduct issues and targeted violence. In the wake of devastating school shootings, I'm sure this is on your hearts as it is on mine. As a mother of a senior in high school and 2 in college, anytime you hear something, your heart breaks and you just wonder how this is happening in the world today. I feel like we were talking earlier, I feel like it was so much better when we were younger. The CMPD supplies full-time school resource officers to all high schools and middle schools in the Charlotte-Mecklenburg school system to provide a safe learning environment. Lieutenant Stephen Flatt has served in various roles with the Charlotte-Mecklenburg Police Department for 21 years. He has worked in the Steel Creek Division as a patrol officer and patrol training officer, as a sergeant in the Hickory Grove Division, and as a lieutenant in the North Division. Lieutenant Flatt has a master's degree in criminal justice from the University of North Carolina in Charlotte and is currently the lieutenant in the Community Services Division and Educational Outreach Department, which is responsible for the School Resource Officer Program and several youth initiatives. Thank you, Lieutenant Flatt, for being with us today.
So thank you all so much for the invitation. I think it's strange getting called a school safety expert. I don't necessarily know if I am the expert. However, I've been over the School Resource Officer Program for about 1.5 years now. And what we're going to touch on is just kind of an overview of what the School Resource Officer Program strives to do and what we are seeing in schools right now with juveniles, specifically some of the challenges that we face and that we're seeing. So to start, flip through some stuff. And again, I'm going to probably rush through some of these slides pretty quickly since we have a limited amount of time. Quick overview of CMS. Over 140,000 students are in CMS. It's one of the top 20 school systems in the country. If you look right there, a quick breakdown of schools, there's about 170 schools in the CMS system. That's in Mecklenburg County, and that does not include all the private schools and charter schools that are around. There are just a ton. I read just about any report that comes through anywhere in the county at any of the schools. So even though we have a school resource officer program, we only touch a small portion of those schools. We contract with CMS. There's 51 SROs. We're in 48 schools. We basically cover all the high schools and middle schools that are in our primary jurisdiction. Huntersville has several high schools they cover, and Matthews covers Butler High School, so forth and so on. But again, I typically get to hear about everything that happens all over the county. So this is actually straight from our standard operating procedure about what SROs are supposed to do. So I'm just going to hit on the goals of the partnership. Obviously, we want to prevent juvenile delinquency. Our primary goal is to maintain a safe and secure environment for schools to operate. We want to prevent criminal activities and disturbances. That's a big one that we harp on a lot. We are only there to get involved when it's criminal. We do not enforce school rules. We do not, that's the administration and the teacher's job. It's only when it rises to a criminal level that we typically get involved. We're there to promote positive attitudes related to police, to teach students some of their rights and responsibilities as citizens. We actually have a program called the CARES program, which talks to students about their civic duty and their rights and what to do if they ever encounter police officers. And then obviously to establish a positive working relationship with the school and the surrounding community. We really want SROs to be, sorry I say SROs, we love acronyms, school resource officers. We really want them to be somebody that people feel very comfortable to go up and talk to, parents, school staff, students, anyone. You may not know police officers in general, but you at least know your SRO. So real quick, I'm not going to harp on some of these figures real quick. This is just last year compared to this year, things that go on in school. There's over 2,600 reports taken in school last year. Now that does include summer, and it also includes any report taken out of school, even if it's on a weekend or after school hours. But if you do a quick breakdown, again, summer programs are the number of reports are very few, but I did include them. If you divide it by 9, which is about the months of school, we're averaging about 290 reports per month at schools. I'm sure you guys saw in the news last year, there was a record number of firearms found at CMS schools. We had 31 recovered. 28 of them were by CMPD in our jurisdictions, and 3 of them were recovered by Huntersville. There was one case of a gun that was fired at school. If you guys remember, it was December, West Charlotte High School. A student actually did fire the gun at school. Luckily, nobody was injured. There was no major injuries at school last year regarding to any crimes, pretty much. And we'll talk about the school threats here coming up. But if you look, it's just a quick breakdown. You'll see that if you don't know what a fray is, it's basically a public fight. A fray and assaults account for about a quarter of our calls, and then we have larcenies and all kinds of stuff. But if you compare it to this year, graph looks pretty similar, and we're averaging in the first month 280 reports in schools. So we're pretty much right on the same trajectory. However, the one thing we have seen gone down is the number of weapons that have been discovered in schools this year has dropped. Causes, reasons, not necessarily sure. We'll talk about some things here later. So what I really want to talk about is the calls that tend to receive the most attention, get the most media coverage, things we really focus on. The 3 biggest ones are weapons in schools, school threats, and sexual assaults. So if you guys see I know it's hard to read there with the little threat, and I really wanted to find the original threat. But last December, there was a nationwide viral threat that went out on social media that just went all over the country. And the original threat said, on December 17th, pray for everybody at school. That was all it said. And it swept across the country. It didn't mention which school was mentioned. It didn't mention what state. It didn't mention what it really meant. If it just meant to pray for students right before exams or what. But it was taken as a threat, and because of that, about half of the students in Charlotte-Mecklenburg didn't go to school that day. Got spread all over everywhere. There were articles written. We actually got overseas tips from other countries who called the Charlotte-Mecklenburg Police Department to say, I just saw this online, you need to be aware of it. So, sleepless week for me. But in the end, nothing happened. So again, we're going to talk about some of the viral nature of these threats and how they go around. So that was a really big one last year. So obviously weapons. So there is a sense of ease in getting weapons nowadays, especially for juveniles. I think some of my former speakers talked about gun ownership's on the rise. I was going to ask you guys what you think is the most easy way for kids to get weapons, but I'm just going to run through them for the sake of time. So first off, I'm sure you've heard about in the news, LFAs, again, my acronyms. That's a larceny from auto. A ton of guns are stolen from cars. If anybody has been on Ring or Nextdoor or some of those apps, I'm sure you've seen a video of your neighbors posting kids walking around pulling on door handles at night, looking in cars. They're finding guns. Last year we had over, almost 1,100 guns were stolen from vehicles. And those stolen guns are very often used in criminal activity. We are actually we're on the pace to kind of eclipse it just by a little bit this year. We've had already about 800 stolen. So please, responsible gun ownership. Do not store your gun in a car. Do not leave it where it can be easily accessible. That's one of the reasons, again, more people are owning guns and they're easy to find. The internet. So the picture right here, has everybody heard of a ghost gun all over the news lately? So the gun on the left, that's kind of the grayish color, that is what we refer to as a ghost gun. You can buy the parts. Anyone can buy them because you don't have to because it's not a gun, it's just parts of a gun. And you can literally take all those parts and with the tools in your garage, within 10 minutes, you can convert it to a fully functioning gun. It basically matches, that's a Glock right there on the right. So you can see how they're basically the same thing. And kids can order this stuff on the internet. There's actually instructional videos to show you how to turn these parts into weapons. We've seen a very large uptick in them since about January of last year. They do not have serial numbers on them. There has been some recent legislation passed to stop this issue from going on, but again, we seized multiple guns from kids this year that they basically ordered online. I mean, as young as 14 to 15 years old. And then lastly, family. Obviously, if you have a gun in your home, access to them. We'll talk later about some school shooters. Most school shooters do obtain their guns either through family or through legal means. So that is a big thing. Again, responsible gun ownership. Please make sure you lock your weapons up. I will say that we've been asked multiple times about the guns that were collected last year. We saw them from all over the place. Very few of them were taken from family that we could prove. A couple, but not a ton. So again, guns are out there. Juveniles have a much easier time getting their hands on them now. And if you guys saw back in July, we even did a press conference on how bad juvenile crime has gotten. Juvenile crime is definitely on the rise. Violent crime in Charlotte in general is up a little bit this year, about 1% to 2% depending on the week. And a lot of that is based on juvenile crime. We had 118 juveniles in firearm-related crimes back in July, and those are the ones we know about. So those are the ones we've caught them doing. There's a bunch of others we haven't solved yet. We don't know if they're juvenile involved. But obviously, juvenile crime is on the rise, specifically firearm-related crime. The one big change from last year to this year, CMS did install metal detectors in schools. I'm sure you guys saw lots of that on the news as well. Now, has that been the reason why weapons have gone down? Really don't know. It hasn't taken care of it absolutely. Or like I said, we've already found a couple guns this year. Weapons still do get through. But maybe the idea of it being harder and more difficult to get the weapon inside the school might have an effect. We don't really know. So, all right, social media threats. So this is a picture of a threat that we had come up 2 weeks ago, 2 different times at 2 different schools. I actually was able to track down the kid who originally posted it, and he told us he Googled online school threats, and this is what he got. And then he just took the picture and reposted it because he was mad because he was getting picked on. So again, social media, some of the top sites, I'm just going to let you look at them real fast. Facebook, even though it is the top site, it's more of an our generation type of thing. A lot of kids are using Instagram and Snapchat, and anybody who knows me will tell you very quickly I am not into social media and I don't understand half of this stuff, so I'm just a little ignorant on it, but I've learned a lot by being in this position. A lot of our threats that we do see are Instagram, Snapchat, and we'll talk about TikTok here a little bit. So if you guys didn't see this, this is last year's TikTok challenge that went out to students, which basically are almost all criminal in nature. And what the kids would do is they would videotape themselves doing this behavior and post it on TikTok to gain notoriety. We saw a bunch in September with the damaging the school. This is a cleaned up version, by the way. They refer to it as other things. Specifically, they talked about destroying bathrooms. We had several bathrooms in schools. Luckily, we didn't have a ton. We got alerted and noted to this stuff. I know teachers got notified of October's threat because they were very anxious about it and talked to us quite a bit about it. And I think we only had maybe one here locally that happened, but you could see them online. So again, all these challenges are basically criminal in nature. The jab a female is actually to grab a female's private parts. So it's basically a sexual assault, as well as you can see later on down with the males. So again, this is what the internet is encouraging kids to do, and for some reason, kids seem to do it. We haven't seen yet a challenge for this entire school year, but if you saw the news last week, South Carolina had about 15 bomb threats across the entire state because there is a mass active shooter challenge going on TikTok right now. And you can actually get on TikTok and people are pretending like they're in an active shooter situation. And it caused a bunch of stuff going on. And so I think they had about 15 instances last week in South Carolina. Traced it all back to this TikTok challenge and said, you know, it's happening, that's what's going on. So they are still out there. Other social media concerns, is everybody here familiar with swatting? We've had several of those where people make fake 911 calls on other kids trying to get back at them for stuff. That's a big problem. Suicide rates, so I'm not in the medical profession. I looked and saw tons of stats. I've talked and been in a few other conferences. But the biggest thing is that suicide rates are at an all-time high for juveniles. Roughly, I've seen anywhere around 30% is the most common thing that I see right now for males, and it's almost doubled for females, specifically in the age ranges of 13 to 16 years old. So what's the biggest influencer of 13, 16-year-old girls who are driving them to suicide? There's a belief that social media has a very large play in it because it's no longer that they're getting bullied at school, they're getting bullied 24 hours a day. So again, the viral nature of these threats, it doesn't matter if it happens in another state. Somebody can translate it over here and it gets spread around. It's a real pain for us. And then, of course, human trafficking and child exploitation. Talk about that a little bit more here later. We ran a video campaign called Think Before You Post, trying to eliminate some of these fake threats. We investigate every single school threat that comes in, no matter the time or day of night. It is a huge resource drain. In fact, we had, 3 last night that we worked on? They are a daily occurrence. The problem is I can't even tell you how many school threats we investigate because we categorize them in different ways, because there's not necessarily a crime of school threat. It can be a communicating threat. It can be a non-criminal incident if we prove that it's a hoax. So they get kind of lumped into a whole bunch of other areas. But I can tell you it's a daily occurrence. So we're trying right now to come up with some ways to measure it a little better. School threats, I did some research on last year, this year, they're pretty much actually on the rise still. I don't know if we're going to get the video to play. I'm going to skip it. It's just a video we did which basically informs kids that even though you think this is a joke, it's actually criminal in nature and you will be charged. And I will tell you that we are charging kids quite often with this to hopefully get the message around that this is not a game, it's not funny. So we have charged several juveniles with it. Moving on to sexual assaults. So some of the issues with sexual assaults, age classifications. Anybody know the age of consent for sex in North Carolina? 16. So once you're 16, you can pretty much do whatever you want. Before that, 13, 14, 15-year-olds, there are laws about the age of the person you're with, and a lot of kids don't know that, so they can be charged in those areas. The biggest thing is that a lot of behaviors that students think are innocent are actually sexual assaults that are criminal. Slapping somebody on the butt is technically a crime, all right? Like the TikTok challenge, the stuff they talked about, grabbing, that's criminal. So kids think this is just playful joking around, but they can get charged with a crime, which kind of influences how our sexual assaults are measured. And again, it's not gender specific. Boy on boy, girl on girl still counts. We've had some where they're like, well, I can't be charged with that because I'm a guy, messing around in the locker room with another guy. Well, no, you think it's a playful thing, but it is actually criminal. We also get a lot of stuff reported through schools that happen elsewhere, so it gets kind of put at the school because they don't know where it happened. Again, that's kind of a direct reflection of the trust that students have with the school resource officer. They feel comfortable coming to them and talking to them even though they may not call from home. The biggest thing we see, we have a bunch of issues with sexting. If you guys don't know what that is, that's the taking pictures and sending them out. All I can say is do not send it to anyone. If someone shows you a picture and says, I got sent this, don't say, well, I'm going to send it to the principal at the school so they're aware of it, because now what have you done? You've technically sent child pornography, all right? And we have issues with that, where teachers are doing what they think is right, but they're continuing to propagate and sending stuff, and it gets all messy. We're going to talk about what you can do here in a little bit. Please talk to your kids. A lot of kids, when two 15-year-olds are sharing pictures of themselves, they don't think anything of it, but once they then start sending it to their friends, now you're sending out child pornography. We deal with it all the time. In fact, this is a video. Again, I'm going to skip it in the sake of time. If you guys want to Google it, consent, simple as T. Basically, our sexual assault unit told us if we want to show kids kind of some rules around sexual behavior, this is a great thing. It kind of breaks it down about, forcing people to drink glasses of tea. It's, it's a little humorous, but it also kind of gets the point across. School shootings. I spent a week at a national conference this summer talking about school shootings, 5 days straight of talking about all the worst things in the world, pretty much, real uplifting. The main thing they wanted to harp on is they are still rare. We talk about them all the time. They tend to have a massive impact, but they are still a rare occurrence. I really like Dr. Jacobs' slide that talked about mass shootings do account for a very small number of victims. So they just tend to be such a horrible event. Talk about the distinction between feeling safe and being safe. I was in a youth group talking about issues earlier this year, courageous conversations. And we talked to the kids about, do you feel safe at school? And the majority of the kids were like, yeah, I feel safe. And then they started bringing up, well, do you know how many guns have been found in CMS this year? Do you know how many weapons? And the kids are like, well, I'm just used to it because I go there, so I feel safe, but maybe I'm really not safe. So the goal is, and it also goes on the other side too, where you think you're not safe the whole time, but you really are in a safe environment because most schools are a safe place. So again, we really want kids not only to be safe, but to feel safe as well. Studies do show that most school shooters tell someone. I think it's about 98% of school shooters actually talk about what they're going to do and share their plans. So again, we highly encourage kids to come forward and talk to us, to tell us. If you see something, don't repost it, which is what happens most of the time. They just say, hey, I'm warning all my friends, don't come to school, I saw this. No, call the police, because once you've reposted it, now you're spreading a message as well, and you are technically violating the law. That's how, again, the viral nature of this stuff blows up and everybody gets panicked. So again, if you see something, please let us know. What motivates, there's all types of motivations for school shooting. However, the biggest thing that they have seen is they all want to one-up the next person and have the highest body count. And then we all learn from each one. The current challenges that we're seeing after Uvalde is that whenever something happens at a school, the parents want to come in even if we tell them we got it under control. And we've had some issues with that. I get it. My kids go to CMS too. So, but just be aware of that. So that's a current challenge we're facing. The prevention techniques that we use, we try to do a layered approach, make it so hard for somebody to actually get to the kids. We do threat assessments. Whenever we identify a school threat, we do what we call a threat assessment, which is where we go out and see if they have access to weapons, if they have the ability to actually carry this out. CMS does a threat assessment as well, where they meet with a team of school officials and medical professionals to try to decide what's best resources for this child. The challenge is that unlike most cases that police have where we make an arrest and we close the case, you never really close a case on someone who's talking about shooting up a school, because just because they didn't do it their 9th grade year, what's to say they won't do it their senior year? So then who's responsible for kind of keeping tabs on this person? So anyways, again, training, videos, we do an active shooter training through the department if anybody ever wants us to come out to your company. CMS does one with all their school officials. They do lockdown training and drills. The basics are you'll either hear run, hide, fight, or the ABCs, avoid, barricade, and confront. The video I have here, again, skipping it for time, is actually a video that Florida State University made that they showed to all incoming freshmen, where they actually kind of simulate a active shooter and tell you what to do during it. A lot of universities are doing that now to get the training out to their students. So here's the big thing. What can you do? So first off, you gotta talk to your kids or be involved in kids' lives. I know everybody in here, if you don't have kids, you probably see them at church or involve them somewhere. Talk to them. Be involved with them. Let them know what is appropriate and what is not. And that's at school, that's around their peers, and especially online. Making fun of somebody or making threats online is not a game. It's mean. It can affect people. All right? And then tell them what to do if they become aware of something. Again, tell an adult, tell the police. Don't just keep reposting or re-talking about it. Know what your child is doing online. So I know some people don't want to be nosy, but you got to check what your kids are doing. How much time are your kids spending on social media? How much time is acceptable? I was in another group where we talked about this, and I remember one girl in there was like, well, I limit myself to 3 hours of social media a day. And I was like, oh my gosh, how does she even find 3 hours to spend on social media a day? And then they asked me, and I said I spent about 3 minutes, and they all made fun of me for being an old, square, which I am. So again, know how much time your kids are spending online and what they're doing online, and not only themselves, but what their friends are doing. After the Hopewell incident last September, we got on the news and talked about, please parents check your kids' social media. We got tons of calls where like, hey, there's a young kid holding a gun in a picture online. Well, if y'all don't know this, a lot of kids take pictures with guns online and post them, with drugs and money too. They think it's like the cool thing. So even if your kid's not posting it, but his best friend is posting pictures holding guns, what should that tell you? All right? So it was great that parents actually listened to what we said and went out there, but it was also, I think, an eye-opening experience for them. So know who your kids are hanging out with and what they're posting online, because when violence happens, it's not necessarily to the person it's meant to happen to. And then lastly, report stuff. There's many ways to report. 911 through your school resource officer, Crime Stoppers, the Say Something app that came out last January that the school uses. We get a ton of stuff through it. It is anonymous, which is great because it encourages people to report things. However, you got to give me something to go on. When you anonymously report and you say, hey, I heard there's going to be a shooting at this school, and that's all I have, I don't really have a lot to go on. So the more information I can get, the better. And that's going to be it. So I would ask for questions, but I think we're going to do a panel discussion now, correct? So there you go.
Thank you. Thank you so much. So if you just want to stay in here, yeah. It was interesting. It was very informational. And one of my first thoughts when you were talking about kids with guns was, where are they getting the guns? So it was interesting to see your slide about weapons. So thank you. Your role is very important, obviously. If all of you would come back to the stage, Dr. Pullen and Dr. Jacobs. And I'm going to ask you guys a question, and then we'll open it up for anyone else that might have a question as well.
Give the old guy a little lick.
Oh, you're good. You're good. No rush. Okay, so any of you are free to answer. Everyone can answer, however you guys would like to do it. How can the medical community, health department, and law enforcement work together to treat community violence as a disease while still keeping our communities safe? What needs to happen to organize this effort? Who wants to take the first stab at it?
I guess I can start. I think as with a lot of these kinds of questions, I think there's probably lots of different ways that we could think about it. But I think we've actually seen a lot of great examples across the country where law enforcement has partnered with community health departments, health systems, and different strategies have been tried, and a lot of them have been successful. As an example, embedding a clinical social worker, for example, with law enforcement has been immensely helpful in a lot of different spaces where that's been done. It has helped law enforcement when they, say, are out on patrol and they are encountering persons who may have some kind of mental health condition. And it's I think, helped with, I think, appropriately assessing those situations, making sure that the way that person is responded to is done in a helpful way, in a way that's appropriate, both from a law enforcement standpoint, but then also from a mental health standpoint. I think I've been a part of many conversations where our physicians and healthcare providers have sat down with law enforcement, and those conversations have always been highly productive. I think what's needed going forward would be taking those kinds of things to scale.
So, I think I turned it off. Hello? So, yeah, I would agree. I think that we already have some good examples here in Charlotte. I know that there was a program, I'm not sure whether it still exists, that was actually run by CMPD, recognizing the toll that violence takes, particularly when it's witnessed by our young people. And they would let our public health folks, our mental health folks, know when a young child had witnessed some violence. And they would come to the scene. They would come to the scene and begin intervention there and then. I presume that program is still ongoing, but that's just one example. I am a real fan of the notion that violence requires a multidisciplinary approach. We all look at this elephant very, very, very differently. And as you all know, Charlotte tends to work in silos. And so if we can break down some of these walls that sort of separate us and begin to look at whether it's the community, whether it's the individual, and focus on that and not so much where we whatever role we may have, I think we're going to have more successful outcomes. But that's just one example, I think, of a successful program.
Yeah, I mean, to say the same thing after the doctors, just the collaboration with the health field. We do have the program he's referring to that addresses childhood trauma, CDCP, still going on, very active in that, or it was for a long time, where we try to recognize children who witness trauma can typically get into a cycle of violence, so we try to address it, as well as we have a program where we work very closely with mental health clinicians. Some clinicians actually ride with officers to address certain calls. And I will say that overall, I think law enforcement has done a very good job, specifically with mental health, especially the past few years. It's been the buzzword, but that's not the only thing that leads to violence, and we know that. So we know there's still areas that we need to do to address other areas of violence. But I think, again, it's just the collaboration and coming up with a program where we can work with them. And specifically, I think I love Dr. Jacob's slide about the primary, secondary, tertiary. We usually see the kids once the violence has already occurred. It'd be great to get them beforehand and try to interrupt them then. So again, I think that's the importance of school resource officers being in school and people talking to them about what they're seeing and what they're hearing, so that we can try to get involved early to have the better effect, and wait till it already happens and try to fix it. But, yeah.
Thank you, guys. I want to open it up to the audience now. Is there anyone that have, yes, please, address the mic. Thank you.
I was glad to see on the slides that in spite of the media, the news media, and the optics of politics, the actual number of deaths from mass shootings, especially in schools, is very, very low. But given that, what is your feeling about the initiative in several states of arming or having the teachers carry a concealed firearm? And first to Officer Flatt, and then the others. Thank you.
So, yeah, I didn't give my disclaimer about getting political, but I guess I should. everybody has their opinions on things. We discussed that at our national conference in school safety. I mean, you can argue it either way. You've seen in like Dr. Jacob and Dr. Boland's slideshow that sometimes the number of guns leads to what? More gun crimes. So putting more guns in school, would that be a good thing or a bad thing? There are several things to consider, specifically how those firearms are going to be secured and stored so that no student can get access to them. There's a training aspect. How often if a teacher is going to carry that weapon, how often do they actually train with it? Would they actually be able to hit what they're aiming at in the situation? Studies show that even police officers only hit their target about 30% of the time. Because under stress, it's a whole different ballgame. So there are all kinds of arguments for and against. You have to consider that. I will say there's one of the things that came up at the conference was discussing that each school district is different. We're here in Charlotte. We have police services usually just a couple minutes down the street. But if you're talking about out in Wyoming where your nearest police officer is 60 miles away, maybe it's a different conversation. So again, it's not a guarantee. Again, there's no easy quick fix. There's no one solution, and so you have to think about those things. So I would say that I would lean towards not encouraging that personally, but again, that's just kind of my view based on what I see.
Yeah, I don't want to touch that question. But what I will say, because I'm off on a different tangent, but what I will say is that the presence of police, school resource officers, whatever you want to say in schools, I would just like to look at it from a different perspective and tie it in a little bit with what I mentioned. And we talked about that balance between risk factors and protective factors and the things that can be done. And in many, many situations, a relationship with a school resource officer is the most important thing in these kids' lives. They don't have a relationship with a caring adult at home. Maybe there's a coach at the school, maybe there's a teacher, but that school resource officer knows what's going on in the community, knows what's going on in the school. And so, we heard a lot about the enforcement part of it, but please don't forget about the importance of supporting those programs because they really provide a lifeline to many of our kids. And that balance that we're talking about in terms of them adding another layer of protective factors. So I just didn't want that opportunity to be missed.
Question?
Yes, I'm Sue Head. I'm a nurse with a psych mental health background. And I think a question that came up was what can we do as a medical community? I think one thing is I believe that we're a brother's keeper. And I think if we could reach out and mentor and affirm people that are in this cycle of poverty or violence, that really helps. I live at a CCRC. We have people, students working in the dining room. We try to affirm them and mentor them. But one thing I found in studying this some time ago, that poverty gives people little hope. And when you don't have hope, you don't live in the here, you live in the here and now for survival. We have to help people have hope for things to be different. And I have a question for you, Lieutenant Flatt. What about, I have heard from teachers a lot saying that there is no respect for authority. Have you found that being a problem in the school systems? The parents not really supporting the authority figures, but supporting the student when they have misbehaviors or so forth. My daughter's a teacher, and she said this was a real problem with her.
So I come from a family of educators. Both my sisters are teachers. My mom's a teacher. My aunts are all teachers. My grandfather was a teacher. My mom said I was the black sheep of the family. I became a police officer. As far as respect, I mean, I'm going to say, yeah, sure, probably it's gone down a little bit, especially, hearing from what my sisters deal with in schools and the parents and everything. But that's, again, that's kind of a generalization of we tend to focus on the negative things, you know. Again, is it everyone in your class that's really being disrespectful to you, or one? As police, we see the majority of crime is committed by 10% of the people. You know, 90% are still good. So, I mean, it's just a subjective question. But I mean, I think as we even talked about earlier, yeah, it was better when we were kids. Well, was it really, or is it just that's what we were used to and what we were,
I
you
saw
know,
the
accustomed
principal,
to?
I'd be scared to death when I was growing up in school. So anyway, I want to go back to the fact that we each individually have a responsibility to bring people up. And if we know somebody that we can help them climb up that ladder, I think it's really important. So the young people that work where we do, we try to affirm them, we mentor them, we support them for educational goals and so forth. But I think it's important. Thank you for coming. I enjoyed the program.
Yeah, can I just make a comment about this? I'm trying not to monopolize this. But to your question, how many of you, I know the answer to this question, how many of you are familiar with the concept of trauma-informed care? I mean, we better see every hand in this audience up. And so we typically, when a child is acting up or doesn't have the appropriate respect for authority, we tend to say, what's wrong with this kid? What's wrong with you? And we don't realize that this kid, before he even got to school, didn't have breakfast, saw his father abuse his mother, got in a fight on the school bus, didn't get his homework done, got yelled at by the teacher in the previous class, and then he shows up in your class and he's acting out. Lack of respect may be the way that manifests itself. And so you all that work in this area know a lot more about this, but you turn the question around. And so when a kid comes in, he's acting out, the question becomes, what's going on? How can I help you? How did we get to where we are today, as opposed to the sort of almost the victim blaming kind of situation that we've all sort of grown up with. So if you're not familiar with that concept of trauma-informed care, I think it really becomes important, particularly as we're dealing with today's youth. Thanks.
And keeping snacks in your office. So Shanavia Montgomery, I'm the Executive Director of CareRing, and I am joined here today by Maya Finkster-Jones. Say hi, Maya. With CEO or Center for Employment Opportunities. We are grateful to be one of the Safe Charlotte recipients. I want to thank Dr. Jacobs and Ms. Hurley for the support, and our system partners for us to be able to navigate this new terrain. We will be providing comprehensive health and mental health services to the individuals that are receiving workforce development services with CEO as a part of that. Safe Charlotte is, as noted, one of the violence prevention initiatives that the City of Charlotte and the United Way are initiating. We are in uncharted territory for both of our organizations, and we're excited to be able to put that clinical social worker or that therapist into this space. We know that trust building is the foundation and the key to doing that. So we've done our due diligence in trying to incorporate the potential participants and the staff of CEO in our development of this program. But my question to you is, how can we go about continuing to build that trust along the way? We are trying to prevent recidivism, and we know that providing mental health, especially with the population that we're working with, you know, we're learning, but we know that there's incredible stigma behind it. So how can we continue to engage in this cross-cutting collaboration, thank you for that slide, Dr. Pullen, along the way, and try to reduce some of the barriers that we know exist within the medical community and law enforcement so that we can gain ground and hopefully help prevent future violence.
Yeah, it's a great question. You know, when we're talking about building networks and cross-cutting collaboration, trust is such a, I think is such an important currency to those kinds of relationships. I think, there's lots of perhaps different, ways, that one could, think about answering that question. I think as within any partnership or any collaboration that's occurring, any intervention that we're doing for our young people, our interventions have to go beyond words and talk, right? They have to be reflected in, I think, our actions. And so if young people don't perceive, or, in any relationship, right? If you don't perceive that there's, actions that are following, whatever the commitments are, that can erode any trust pretty quickly, and repeating that over time can build a sense of kind of cynicism, or our young people just not having a much higher threshold for being willing to engage. But as with anything, it always comes down to relationships, and so part of that action is investing, right, in those relationships as a place to start, and maybe acknowledging that we may not have all the answers because of complexity of problems, the complexity of this problem of community violence. But I think being present and following through, and being in it for the long haul are probably some of the important things that I would recommend.
Okay. If no one else has anything, we want to be respectful of everyone's time. So I'd like to thank all of you today, your panelists, for your expertise, your knowledge, your passion, your time today to be here. The Community Health Classroom is just one of many health, education, social, and volunteer programs that Healthy Charlotte Alliance convenes throughout the year. So please consider joining us as a member. You'll find membership forms at your table. Your membership is not only a philanthropic investment, but also an opportunity to learn, have fun, and positively impact our community. You'll network with others who are also passionate about our health, our community, building partnerships and referrals. You'll become informed about a variety of health issues impacting yourself, your family, and our community. Our next Lunch and Learn is on November 9th on improving sleep quality. Who couldn't get better sleep? We all want better sleep. I know I don't want to miss this one. You'll engage in hands-on volunteer projects and discover the cause that makes your heart beat. We're looking forward to volunteering with Shelter Health Services on November 2nd. And you'll also be part of a philanthropic organization investing resources to make a meaningful impact for those in our community in greatest need. Membership is accessible with discounts for young professionals as well, and it shows that on the bottom of the form. There's no commitment, rather just engaging with what your interests are and your schedule allows. We don't keep track of how many events you attend or how much you volunteer. If you'd like to become a member, please complete the form and drop it in the box over on the registration table, or you can process your membership by scanning the QR code on here as well, right on the top. Finally, you'll also find a pledge card on your table. Healthy Charlotte Alliance is a 501c3 nonprofit and relies on the generous donations of others in order to continue to fulfill our vital mission. I hope you'll consider making a donation to support us. To donate with your credit card, you can simply scan the Donate QR code on your program with your smartphone camera or complete a pledge card on your table. So this has been a great afternoon. It's been my honor to be up here and to take this journey with you, but do not let it end here. I hope each of you has learned something today or walked away with at least one action step or one small way that you can make a difference. American architect, designer, and inventor Richard Buckminster Fuller said, "Never forget, no matter how overwhelming life's challenges and problems seem to be, that one person can make a difference in the world. In fact, it is always because of one person that all the changes that matter in the world come about. So be that one person." Thank you all for taking the time today, and have a great afternoon.